Hey, my name is Hannah Owell. I'm a student nurse at Cedarville University, and today I'm going to be doing NG tube insertion and a feeding and also a discontinuation. A G tube placement is obviously done by a physician, but we will also be caring for them, and the only difference between a G tube is you would have to be checking the area for signs of infection or anything. So the first thing I'm going to do when I come into the room, I will provide privacy and wash my hands and introduce myself to the patient and check their name. I will ask their name and birth date while checking their armband to make sure I have the correct patient. When I'm sure that I have the correct patient, I'll make sure I get all my supplies. And then I will raise the bed to a comfortable working position. And since I'm going to be inserting NG tube, I will also raise the bed to a high Fowler's position. And that will be about a level of 30 degrees. So first, I will assess the patient's ability to cooperate with the procedure, explain why we're doing it, put a towel over their belly to protect from any spills or anything, and assess their gag reflex. I'll get a depressor thing and just make sure that they have the presence of a gag reflex. And then I will check to see which nostril is most patent by plugging one side and ask them to blow on each side. And whichever one is the most patent, I will use that one to insert the NG tube. Get my gloves ready. Alright, first off, I'm going to assess for bowel sounds to make sure that they are present. Listen in all four quadrants. Now I'm going to check my tubing, make sure that there are no flaws or anything wrong with it. Then I will curl it around my fingers to make sure it's as flexible as possible so it's less painful for the patient. Next, I will measure the tube to see how far I should place it by measuring from the tip of the nose to the earlobe all the way down the xiphoid process. And then I will mark that with a piece of tape that I will have previously taken off and prepared on my table. Okay, now that I'm ready, I will coil the tube in my hand just so it's more easy to do. And then I will have lubricant where I will lube the first 3 to 4 inches of it. But here we use a spray. Alright. As I insert, I will have the patient tilt his head, extend his neck backwards, and I will slowly insert the tube until I feel resistant, twisting it as I go in. And when I meet resistance, I'm going to have him bend his head back to normal and continue to insert until it goes all the way in, up to the mark. Alright, and then I will secure the tube to the side of his cheek. Now I need to check to make sure it's in the stomach, not in the lungs. So the first thing I'm going to do is order a chest X-ray to check for the placement. And now I will also inject about 30 cc's of air into the tube and listen for a gastric bubble when I put it in. I want to make sure I always pinch the tube before I open it so that no content escapes. So I pinch the tube and then I will push in the air and listen for a bubble. And I will also pull out 5 to 10 millimeters of gastric content to check for the pH level. And those are all different ways to make sure that it is in the right position. After we are verified that it is in the proper position, we will measure the tubing from the tip of the nose all the way down to the end and write it down on the MAR to make sure that we know exactly how long it is. Alright, after we have verified that it is in the right position, we will secure it more firmly to the nose and also pin it to the gown. So we'll make a thing. It's a little messy right now, but usually that sticks. And then we will attach another piece of tape down here and use that to pin it to the gown. And making sure that there's plenty of movement in it so that they can turn their heads and not pull on the tube. Alright, to do a feeding, we will come in and make sure that the food is the right kind and it's not expired or anything. Check the doctor's orders. We will also make sure that, you know, we provide privacy, wash our hands and everything, introduce ourselves to the patient. And then we'll let it come to room temperature. And at that time, the bed will have been in the down position with the bed rails up and the call light within reach. We'll raise the bed to a high palate position. And the first thing we need to do is to make sure that the tube is still in the stomach. So we'll first repeat the, we'll first check the length of the tubing to check it against the MAR to make sure it's the same measurement from the tip down to the end of the tubing and make sure it matches what we had recorded earlier. Then we'll listen for the gastric bubble. We'll insert 30 cc's of air into the tubing and make sure that we hear the little bubble. And then we will also pull out a little to check the pH. And this is also while checking the X-ray to verify the placement. Alright, after we are sure that it's in the stomach, then we are going to pull out the residual. The residual is everything that has been left in the stomach. So we will pull it out. And if it's more than 150 milliliters, we will put it back in and talk to the doctor to see what we should do next, because we should not be giving them more food if their stomach is still full of food. If it's less than 150, we will take out all the residual, pour it into a cup if necessary, and then pump it all back in. After we check the residual and put it back in, we will fill our syringe up with 30 cc's of water and then flush the tube to ensure patency. So flushing the tube. And now we will start the feeding. So we will open up the tubing, make sure our food is ready, pinch the tubing, open it up, pour it in, and then let it go in. We want to make sure that this is full at all times and that there's no air getting in. If it's getting too fast and it's a little uncomfortable for them, we can just lower the tube, which then allows it to go more slowly into their systems. When it's done, we'll pinch it again and then cap it, and then fill up the syringe with another 30 cc's of water and flush out the tube again. Right. And then we will lower the bed and make sure everything is safe and leave. To discontinue at NG, we're going to come in and explain to the patient that it will be a lot less painful than the insertion. The first thing we will do is flush the tubing line with 30 cc's of air. And that is to just make sure that everything is gone. So after we flush with the 30 cc's of air, we'll remove all the tape. Provide the patient with a tissue. Make sure the towel's up so it doesn't spill all over, and then slowly and gently pull it out, and then give them a tissue to wipe themselves and make them clean. Something that also with feeding, when you feed a patient, you need to make sure that they're sitting up in the bed for at least an hour after they have been fed before you can lower them, to make sure that they don't have any sort of regurgitation or discomfort. When I'm done, I will throw away all my tubing, clean up my supplies, make sure my patient is as comfortable as they want to be. I will lower the bed, make sure the call light is within reach, ask if they need anything else before I leave, and then I will leave the room and document all that I've done.